Okay.
Yes.
So my name is Fatuma Jama. I'll be your moderator today. I'm an MBCHP 5 student at the University of Nairobi. So welcome to today's CME, the first of the CME series of 2025 by XYZZ. So before we start, I'd like to introduce XYZZ Med. XYZZ Med is a dynamic community of Kenyan medical students from different universities committed to transforming medical education in Kenya. The initiative focuses on creating accessible, locally relevant resources that address the unique healthcare challenges of the region. Kenya's current medical education system often relies on foreign resources that are not entirely relevant to the local context, leading to gaps in the education and preparedness among healthcare professionals. This disconnect also contributes to a lack of public awareness about various medical conditions, further complicating the healthcare challenge in the country. XYZZ Med is trying to address these issues by developing a range of educational resources, including relatable medical illustrations, case simulations, lectures, quizzes, healthcare stories, research, and interactive learning tools. Make sure to check out XYZZ Med on Instagram. This CME series is one of those initiatives that's meant to promote peer-to-peer learning among medical students, because it's often our friends and classmates who are able to explain concepts more easily for us to understand. So today's CME topic is on postpartum hemorrhage, PPH. Our speaker today is Abdullahi Yunis, an MBCHP 5 student at the University of Nairobi. Abdullahi, you can begin.
Thank you, Fatuma. Should I share my screen? Hello, can you hear me? Hello.
Sorry, Abdullahi. Yes, we can hear you.
I can start now. So, thank you for the introduction. My name is Abdullahi, and I'll be taking you through postpartum hemorrhage. So the table of contents for today's session is: number 1, we'll define and classify postpartum hemorrhage. Number 2, we'll go through the etiologies and the risk factors, the causes of postpartum hemorrhage. We'll also go through the pathophysiology. We'll talk about prevention and management of postpartum hemorrhage and some of the complications. So postpartum hemorrhage is defined as blood loss in excess of 500 ml in vaginal birth and in excess of 1000 ml in a cesarean delivery. For clinical purposes, any blood loss that has the potential to produce hemodynamic instability should be considered PPH, because estimation of blood loss can be inaccurate. PPH is further subdivided based on symptom onset. It can be primary or secondary. Primary is within the first 24 hours after delivery, and secondary is between 24 hours after delivery and 6 weeks postpartum. It can also be subdivided into minor, moderate, or severe based on the amount of blood loss. But the problem with this definition is it estimates the estimate of the blood loss are notoriously low. This could be because blood could be mixed with amniotic fluid, or some blood could be dispersed on sponges or towels or linen or on the floor. So you would never actually estimate the accurate amount of blood loss. And also the degree of blood loss varies between patients. So a patient with anemia, for example, would not have to lose up to 1,000 ml for you to notice symptoms. But someone who has a normal HB can tolerate blood loss that would be fatal for an anemic patient. So criteria for diagnosis of PPH: it's usually bleeding that is greater than expected and results in symptoms and signs of hypovolemia. That is low blood pressure, very high respiratory rates, and very high pulse rates. So this table shows you symptoms related to blood loss with PPH, with different percentages of blood loss and how they would affect blood pressure and the symptoms and signs you'd find. Some patients will have signs and symptoms of hypovolemia before excessive blood loss is seen because of bleeding intra-abdominally, retroperitoneally, or in the pelvic floor. There's other criteria for diagnosis. Different organizations have come up with different definitions to gauge or to define what PPH is. So the most commonly used one, the one we use in Kenya, is the World Health Organization, which is blood loss greater than 500 within 24 hours. And severe PPH would be blood loss more than 1,000 within the same time frame. But because of the limitations of accurately determining the amount of blood loss, the American College of Obstetricians and Gynecologists came up with a new definition in 2017, which says PPH is defined as cumulative blood loss of greater than 1,000 ml or bleeding associated with signs or symptoms of hypovolemia within 24 hours of delivery. This criteria applies to both vaginal and cesarean birth. However, ACOG emphasized that despite this updated definition, a blood loss greater than 500 ml in a vaginal birth should be considered abnormal, and particularly if heavy bleeding persists, and should prompt evaluation and close monitoring. The last one in this table, the California Maternal Quality Care Collaborative, it stages PPH based on severity in different stages. So stage 1 would be no PPH, and stage 4 would be very severe PPH. I mean, stage 3 would be very severe PPH. This is also another classification of PPH based on the amount of blood loss and the symptoms you would notice in a patient. This would be important when your patient has a hypovolemic shock. In epidemiology, PPH is the most common cause of maternal death worldwide. It is reported to occur in 1 to 3% of births and accounts for approximately 30% of maternal deaths. Most deaths occur within 2 hours of delivery. Therefore, rapid action is critical for survival, and a majority of women who experience PPH have no risk factors. And the pathophysiology, normally homeostasis occurs upon placental separation because uterine bleeding is controlled by a combination of 2 mechanisms. Number 1 is mechanical hemostasis, whereby contraction of the myometrium compresses the blood vessels supplying the placental bed, resulting in severely reduced blood flow. Number 2 is local thrombosis, whereby the presence or release of local residual hemostatic factors such as tissue factor and type 1 plasminogen activator inhibitor, and systemic Coagulation factors such as platelets and clotting factors lead to thrombosis of damaged blood vessels supplying the placental bed, resulting in reduced blood flow. Abnormalities in these normal physiologic mechanisms have a high potential for massive hemorrhage, because in late pregnancy, uterine blood flow is 500 to 700 ml per minute versus the 60 ml per minute in a non-pregnant state, and accounts for approximately 15% of cardiac output. Etiology: the most common causes of PPH can be considered using the four T's, the mnemonic 4 T's. 1, tone; 2, trauma; 3, tissue; and 4, thrombin. They are in order of how often they are. Tone is the most common cause, uterine atony. Number 2 is trauma, usually injury to the uterine, cervical, or the vaginal tissues. T is tissue, for retained tissue, blood clots, or placenta accreta spectrum. And the fourth T, thrombin, is coagulopathy. For tone, uterine atony is the most common and important cause of PPH and is responsible for at least 80% of the cases. The blood vessels of the myometrium pass through muscle cells of the uterus. When the myometrium contracts, it occludes the uterine blood vessels. That is the so-called living ligatures of the uterus. Artery-related PPH is indicated in 27% of peripartum hysterectomies. How do you diagnose uterine atony? On palpation, the uterus will be soft after expulsion of the placenta. Administration of prophylactic oxytocin after birth is standard practice worldwide to prevent atony. So there's two types of atony. There's diffuse and there's focal localized. Diffuse is the whole uterus is flaccid, while focal is when the fundal is contracted, but the lower uterine segment is dilated. Risk factors for atony: overdistension of the uterus. These examples are multiple pregnancies, fetal macrosomia, polyhydramnios. 2, exhausted myometrium. This could be prolonged oxytocin use or prolonged labor. Anatomic abnormalities such as uterine fibroids and uterine inversion. An infection such as chorioamnionitis. Medications which lower contractions such as magnesium sulfate and anesthetics. Others could be preterm delivery, maternal BMI of greater than 40, which I think was obese, precipitous labor, and one of the most important ones, prior history of PPH. Number 2, trauma. Trauma-related bleeding can be due to lacerations or surgical incisions. Cervical and vaginal lacerations may occur from natural processes during birth or as a result of provider interventions. Diagnosis for trauma. So tissue trauma after vaginal birth is diagnosed on physical examination, but may not be noted until excessive postpartum vaginal bleeding prompts careful examination of the lower genital tract beyond the perineum, including examination of the vaginal and vulval hematomas and cervical lacerations. On cesarean birth, hemorrhage from uterine incision is usually due to lateral extension of the incision. This can result from spontaneous tearing of an edematous lower uterine segment during an otherwise uneventful cesarean delivery, after prolonged labor, or from incision that was made too low or that was not sufficiently curved on the lower segment, or delivery of a fetus through an incision that was small. Bleeding can also occur as a result of uterine rupture, which may be anterior, lateral, or posterior. Risk factors for trauma are cesarean delivery, instrument-assisted vaginal birth, midline episiotomy, precipitous labor, persistent occiput posterior position, uterine rupture, fetal macrosomia, and malpresentation of the fetus. Tissue, usually placental disorders such as placenta accreta spectrum, placenta previa, abruption on low-lying placenta, or retained tissue. They cause PPH because effective uterine contraction and hemostasis of decidual vessels are inhibited. In addition, abruption can trigger DIC, which we'll see later is a complication. Diagnosis: placenta previa and placenta accreta spectrum are usually diagnosed prenatally using an ultrasound. The diagnosis of placental abruption is primarily based on history and physical examination, and also a laboratory studies that show coagulopathy. Retained placenta is diagnosed when the placenta has not been expelled within 30 minutes, or it has been expelled, but not all of it. There's a bit still left behind. Then risk factors include retained placenta. These examples are prior history of retained placenta, placenta accreta, placental abruption and associated hypertension. Abnormal placentation, this could be due to multiparity, prior cesarean birth, advanced maternal age, uterine anomalies, or a history of uterine surgery such as a curettage. Thrombin in patients with inherited or acquired bleeding disorders, coagulopathy, or placental dysfunction can cause PPH. Thrombin is usually a cause of secondary PPH, but it can also be found in primary. In patients without an inherited or acquired bleeding disorder, consumption and hemodilution of clotting factors during PPH can severely impair clotting and exacerbate bleeding. However, coagulopathy is a late finding in these cases. Diagnosis in acute PPH: coagulopathy can be suspected in patients if they have one or more of the following. So, low fibrinogen levels less than 300, thrombocytopenia of less than 100,000, and prolonged PT and or prolonged APTT. Risk factors for coagulopathy could be acquired or inherited. For acquired, it could be amniotic fluid embolism, placental abruption, preeclampsia with severe features, HELP syndrome, sepsis, or fetal demise. Inherited coagulopathies: von Willebrand disease, hemophilia, platelet dysfunction disorder, coagulation factor deficiencies, for example, factor 13 deficiency. Prevention of PPH. Pregnant women can face life-threatening blood loss at the time of birth. Anemic women are more vulnerable to even moderate amounts of blood loss, and PPH can be prevented. So ways of preventing PPH before we get to it. Number one is antenatal assessment for risk factors. Mother should have a minimum of 8 visits where prevention, early detection, and treatment of anemia and coagulopathy should be done. And also ultrasound should be done to identify placenta accreta or even placenta previa in women with a history of cesarean delivery. Number two is active management of third stage of labor, so AMSTEL. AMSTEL reduces the incidence of PPH, the quantity of blood loss, and the need for blood transfusion, and that should be included in any program of intervention. The usual components of AMSTEL include administration of oxytocin, 10 international units IM, or other uterotonic drugs within 1 minute after the birth of the infant. 2, controlled cord traction. 3, uterine massage after the delivery of the placenta. Number 3 is also postpartum care. Mother should be monitored closely every 15 minutes for the first hour after delivery, and you should check for vaginal bleeding, uterine tone, pulse, and BP to check for shock. Number 4 is avoidance of unnecessary episiotomy and assisted vaginal delivery. These are the postpartum care. So recommended checks are airway and breathing, circulation, vaginal bleeding, uterine tone, consciousness or convulsions, abdominal pain, and temperature. Recommended timing every 15 hours from 0 to 1 hour after delivery, and then every hour from 1 to 4 hours, then every 4 hours from 4 to 24 hours, and then conduct more thorough assessments at 1 hour and at discharge. How do you recognize and assess for PPH? Number 1 is by quantifying the blood loss. There's various ways you can do that. There is estimation by just looking, and there is quantitative by measuring. Examples of the both are under the blanket drapes. You can see on the images on your right. These allow collecting of blood into this funnel, and then you can use a calibrated thingy to find out how much blood loss is there. Usually it's done after the delivery of the placenta. I mean, before the delivery of the placenta, but you make sure there is no amniotic fluid within the funnel before allowing blood to accumulate in the funnel. Number 2 is visual assessment, which is not an accurate way of assessing blood loss. This could be soaked sanitary towels, which is 50 to 100 ml, a kidney tray, which is full 500 ml, soaked sheets and clothes 1000 to 1500, and blood on the floor and as well as the bed sheets is greater than 2000. You can also weigh the swabs or the pads. 1 gram equals to 1 ml. There's a formula: weight of the wet swabs in grams minus the weight of the dry swabs in grams equals to blood loss. Number 2, recognize alarm findings and intervene early. Timely recognition of PPH followed by rapid determination of the cause and initiation of appropriate treatment before the patient becomes critical is important to prevent death, as almost 90% of deaths due to PPH occur within the 4 hours of giving birth. Alarm findings include early warning vital signs, standardized maternal early warning systems, MEWS, that target specific vital sign criteria and mandate an immediate response. These are the MEWS. Looks at BP, heart rate, respiratory rate, oxygen saturation, and urine output. So systolic BP of either less than 90 or greater than 160. Diastolic of greater than 100. Pulse rate of either less than 50 or more than 120. Respiratory rate of either less than 10 or greater than 30. Oxygen saturation on room air less than 95, and oliguria for less than 35 mL per hour for more than or equals to 2 hours. Can also include maternal agitation, confusion, or unresponsiveness. Another alarm finding could be a high shock index. Shock index is calculated by dividing the heart rate by the systolic blood pressure. The upper limit of normal in obstetric patients appears to be higher than in non-pregnant women and is reported to be between 0.9 to 1.1. Hook index is used to detect acute changes in maternal cardiovascular system and acts as an early marker to predict adverse outcomes. It's further subdivided into different, but we won't go through that now. Number 3 for alarm findings are low fibrinogen. Fibrinogen level less than 200 is an excellent predictor of severe PPH. It defined as need for transfusion of multiple units of blood and blood products, need for embolization or surgical management of hemorrhage or maternal death. So now we go to management of PPH. So this diagram basically sums up how to manage PPH. There is the primary bundle and the secondary bundle, or the second bundle. On the leftmost upper corner, we look at how to prevent PPH. There's ANC, there's treatment of anemia, and there is acute management of active management of third stage of labor. On your rightmost corner, it says shout for help. As you remember the mnemonic hemostasis. So first, you find out or you diagnose PPH. So this is first you look at blood loss. If it's greater than 500 ml via vaginal delivery or greater than 1000 via cesarean section. When you have that, you move to the first bundle. This can be easily understood using the mnemonic motive. M stands for uterine massage. So you massage the uterus until there are contractions or for 1 minute. O is oxytocin drugs. You give 10 international units IV of oxytocin bolus, or it could be diluted in 500 ml NS over 10 minutes, plus a maintenance dose of 20 international units IV of oxytocin diluted in 1000 ml saline over 4 hours. You can add misoprostol 800 micrograms, which can be given either parectally or sublingually. T stands for tranexamic acid. 1 gram of IV injection of tranexamic acid, and it can be repeated again after 3 hours. IV stands for IV fluids. So you should make sure you have when you're assessing the patient should have 2 large bore cannulas. You should start crystalloid fluids. E stands for examination and escalation. For in examination, you ensure the bladder is empty. You can do that by catheterizing the bladder. Then you evacuate any products of conception, making sure the uterus is empty, so there's no there's no retained plus tissues. You can also check for tears with internal examination and check for placental completion. How do you escalate? You escalate if the bleeding does not stop after the first bundle is complete, or you are unable to identify or manage the cause of the bleeding. The supportive measures for the first bundle are tear repair, catheterize the bladder, empty the uterus of products of conception. So basically in the first bundle, all you have to do is establish the cause. So you remember that 4 T's: tone uterine atony. You give oxytocics and you do a uterine massage. That would probably solve the issue if the issue was tone. The second T was tissues. So retained placenta or retained tissues. You do that. I mean, the second T was trauma. So lacerations, they could be perineal, vaginal, cervical. If they are, that's the cause of the bleeding, you repair the tears. The third T was tissue. You empty the bladder of products of conception. Number 4, thrombin. That one you give tranexamic acid, which will prevent fibrinolysis. If all of that does not work and the patient continues to bleed, you move to the second bundle, which is basically rushing the patient to theater. You start with bimanual compression. This can be either external bimanual massage or internal bimanual compression of the uterus. Another thing you can do is an aortic compression. If that doesn't work, you move on to the uterine balloon tamponade. If that doesn't work, you use non-pneumatic anti-shock garments. Supportive measures for the second bundle: blood transfusion, surgery, or referral if any of those are not possible in your ward, in your hospital. For surgeries, you start with uterine artery embolization. Actually, you start with a compression sutures. So a B-Lynch or buttress suture. If that doesn't work, you go to uterine artery embolization using interventional radiology. If that doesn't work, you go to ligation of uterine and ovarian arteries. And if the patient is still bleeding, then you do either a partial or a total hysterectomy. That's for bimanual compression. That is how you do an aortic compression. So you compress to the left and above the umbilicus. Using your left fist just above and left to the patient's umbilicus. And then you lean over the patient so that your weight increases the pressure on the aorta. And at the same time, you palpate the femoral artery. Once the aorta and the femoral arteries have been identified, slowly lean over the patient and increase the pressure over the aorta to seal it. And to confirm the seal, you just check the femoral pulse. These are balloon tamponades, interuterine balloon tamponades. It's an effective non-surgical technique for the management of PPH due to uterine atony after ruling out retained placenta or retained products of conception or uterine rupture as a contributing factor. What you usually require for a makeshift balloon tamponade is a condom, a Foley catheter, a rubber band or a suture tie, a 20cc syringe, and 500 ml of normal saline. Once you've attached or you've made the balloon tamponade, you insert it into the uterus and inflate. The uterine fundus is palpated and a mark is made on the abdomen to monitor for any further uterine distension indicating ongoing bleeding. After you've inserted the balloon tamponade, You give an IV infusion of 40 international units of oxytocin in 500 ml of NS for 8 hours. The balloon tamponade should stay in place for at least 6 to 24 hours. Within those 6 to 24 hours, you monitor the patient's vitals, the fundal height, signs for increased vaginal bleeding, urine input and output. Urine output. To remove now the balloon tamponade, you drain 50 ml every hour, observing for return of bleeding, and reinflate if bleeding continues. If bleeding does not stop in 15 minutes, you move on to the next procedure, which is usually surgical procedures. These are the non-pneumatic anti-shock garments. These usually direct blood flow from non-vital organs to the vital organs, such as the heart, the lungs, and the brain. The non-pneumatic anti-shock garments reverse shock by compressing the lower blood vessels, decreasing the container size of the body, so that circulating blood is directed mainly to the core organs, such as the heart, the lungs, and the brain. It also compresses the diameter of the pelvic blood vessels, thus decreasing blood flow. These are compression sutures, a B-linch, and a simplified brace suture. These are also ways to manage PPH if the cause is uterine atony. If that doesn't work, now you move on to bilateral uterine or ovarian artery ligation. And if that doesn't work, then you go to hysterectomy. So complications of PPH is anemia, is hypovolemic shock, is thromboembolisms, the Sheehan syndrome, which is hypothyroidism caused due to ischemia and necrosis of the pituitary gland due to severe postpartum hemorrhage. Is risk of infection, is maternal death, is DIC, and abdominal compartment syndrome. For a question to finish off, select the most likely diagnosis. 36-year-old woman, gravida 4, para 3, at 35 weeks gestation is brought to the emergency department for the evaluation of a sudden, painless, bright red vaginal bleeding for the last hour. She has had no prenatal care. Her third child was delivered by lower segment transverse cesarean section because of a preterm breech presentation. Her first 2 children were delivered vaginally. The patient's pulse is 100 beats per minute. Respiration is 15 breaths per minute. Blood pressure is 105/70. Examination shows a soft, non-tender abdomen. No contractions are felt. There is blood on the vulva, the introitus, and on the medial aspect of both thighs. The fetus is in a cephalic presentation. The fetal heart rate is 140 beats per minute. 1 hour later, the bleeding stops. So what is the most likely diagnosis? Can someone try?
There's some answers in the chat box. You can see them.
Yeah, I've seen them. Yeah, okay. So the answer is B, placenta previa. So placenta previa usually affects women greater than 35 years. And she also has a risk factor for placenta previa. She's had a previous cesarean section. Then what else? uh, and like many of the most important differential diagnoses for antepartum hemorrhage, it is characterized by a sudden onset of vaginal bleeding. But contrary to the other causes of APH, such as placental abruption or uterine rupture, bleeding is painless and often stops spontaneously after 1 to 2 hours. Other differentiating factors are an untender uterus and a lack of fetal distress in placenta previa. That was the end of that.
Okay, thank you, Abdullahi, for that presentation. So now we'll move to Kahoot. We'll do a quiz. Felix, if you can project your screen.
Yes, give me a second.
So before we continue, if anyone has a question, you can leave it at the chat box or you can unmute.
Can you see my screen?
Yes, we can see it.
Okay.
Okay, guys, you can join Kahoot. It will give you a game pin, and you can enter the game pin, or you can scan the QR code to start. Okay, people are joining. As we wait for people to join, Felix will paste a link to a study on the chat box. Kindly would really appreciate if you could take part in the study. It will only take 2 to 3 minutes of your time, and it's on a public participation study among Kenyan youths towards new reversible vaso-occlusive male contraceptive methods in development. Please, if you could participate. Okay. Okay, people are joining. Kakashi. One more minute, then we start. So you answer the questions as fast as possible to get more marks, more points. Okay, I think we can start now. Remember, guys, first, okay, what is the most common cause of PPH? You have 16 seconds left. Very nice. 12 of us got the correct answer, which is uterine atony. Next. Okay, Lord Ryden is in the lead. Then CM Punk. Postpartum hemorrhage is defined as blood loss of more than okay, we all got that right. N is leading. Next. Which of the following is not part of the initial management of PPH? Okay, 17 of us got it right. Medic is on the lead now. Next. Which drug is most commonly used to prevent PPH? Okay, oxytocin. Good. Lord Ryden is back. Which of the following is a risk factor for uterine atony? Remember, the faster you answer, the more points you get. All of the above. Lord Ryden still. Which of the following is a first-line uterotonic agent in the active management of third stage of labor? Yes, oxytocin. Next. Okay. Which of the following is not a risk factor for PPH? Early cord clamping. Oh, sorry. Which uterotonic drug is contraindicated in women with hypertension? Yes, methylagonovir. Lord Dryden. Oh, Medic is now on the lead. Carboprost is contraindicated in patients with yes, asthma. 50-50. Okay. Which is the most appropriate step in patients with ongoing vaginal bleeding despite normal uterine tone after delivery? Look for genital tract trauma. Okay. Which of the following is not a component of the 40s mnemonic of causes of PPH? Yes, tumor is not. Next. Okay. Which of the following is the most appropriate next step in managing uterine atony and responsive to uterotonics? Nice. Bimanual uterine compression. Next. Okay. And is rising. Which of the following statements about tranexamic acid in PPH is true? It reduces mortality if given within 3 hours of PPH onset. Correct. Okay, next. A woman with severe PPH is unresponsive to medical management. Which surgical interventions is least likely? Salpingectomy. Most of us got that right. The symbol is now leading. Which of the following laboratory findings is most concerning in a patient with severe PPH? Okay, fibrinogen level of less than 200 milligrams per deciliter. The symbol is leading. Which of the following blood products is most useful in management of DIC due to severe PPH? Cryoprecipitate. Unfortunately, most of us didn't get that right. Okay, now N is leading. Which surgical technique is used for uterine compression in case of refractory PPH? B. Lynch suture. Good. N is still leading. Which of the following is not an indication for an emergency peripartum hysterectomy? Yes, mild PPH after normal delivery. We all got that right. Woman with a history of previous CS presents with severe PPH. Ultrasound shows abnormal placental invasion of the myometrium. What's the diagnosis? Placenta increta. Which of the following measure is recommended to prevent PPH in all deliveries? Yes, routine prophylactic uterotonics. In the management of PPH, which is the correct ratio for transfusion of blood products in a massive transfusion protocol? Okay, the correct answer is 1:1:1. Packed RBCs, FFPs, and platelets. Also didn't know this. Interesting. Next. Which imaging modality is most useful in diagnosing retained products of conception in patients with secondary PPH? Ultrasound with Doppler. Next. Okay, N is still leading. Which of the following is not a component of the shock index, which is useful in assessing hemorrhagic shock in PPH? Yes, respiratory rate. Okay, Lord Dryden is coming back and the symbol is still leading. In patients with placenta accreta spectrum, which of the following management strategies is generally recommended? Yes, immediate hysterectomy after delivery. And is back. Next. Which of the following statement about uterine balloon tamponade is true? Yeah, used as a temporary measure before surgery. 7 of us got that right. Next. Oh, we are done. Medic is at number 3. We have at number 2, N. And the winner is that symbol. I don't know what that symbol is. If you could unmute yourself, introduce yourself, and maybe tell us what that symbol means.
Hi, I'm
Hi.
Jess. I just chose it because it looked cute.
Thank you. Congratulations. Okay, there's someone with a question. Abdullahi, she's asking, kindly repeat explanation for the previous question. I think the question you had in your presentation. Abdullahi, are you still there?
Yeah, I'm here. Can I share my screen again?
Yes, please. The question is, kindly repeat explanation for the previous question.
Oh, okay. So we said the answer was placenta previa. Let's just go through like the rationale of the question. So it says there's a 39-year-old woman. So there's risk factors. Is okay. 2 things you should highlight. Gestation is 35 weeks, so just gestation, and then she presents with sudden paleness, bright red vaginal bleeding. Okay. She has also had one history of a cesarean section because of a preterm breech presentation. And on examination, the examination shows a soft and tender abdomen. No contractions are felt. There is blood on the vulva, introitus, and the medial aspect of both thighs. The fetus is a cephalic presentation, and the fetal heart rate is 140 beats per minute. 1 hour later, the bleeding stops. This mother hasn't given birth yet. Okay. No. And there's no non-reassuring fetal status. So that would rule out A, which is uterine atony. It will also rule out D, uterine rupture, because the bleeding stops within, what do you call it, within 1 hour. And then also in uterine rupture, you'd have signs of fetal distress. And the abdomen would be tender. And the mother would be hemodynamically unstable as well. E is also wrong. It can't be latent phase of labor. Why? Because of the small amount of vaginal bleeding. No. Because, oh, wait. No, I'm confusing myself. Let me just say, the answer is B, placenta previa. Why? Because it typically affects women greater than 35 years old with a history of surgery. So she has a history of cesarean delivery. Like many of the most important differential diagnoses for APH, it is characterized by a sudden onset of vaginal bleeding. But how do you differentiate the different causes of APH? They're either painless or painful. Contrary to the other causes of APH, such as placental abruption or uterine rupture, bleeding is painless in placenta previa, and it often stops after 1 to 2 hours. Other differentiating factors of placenta previa to the other causes of APH are an untender uterus and the lack of fetal distress in placenta previa. Is that okay? I'll ask the question.
Yes, that's okay. And Rahima says no contractions, so not in labor. So thank you, Abdullahi, for that. Thank you, guys. Please participate in the study and also follow XYZZ on all socials. Thank you very much and have a lovely weekend. See you next week.